You haven't signed up for Connect? Are you nuts? You're missing out. You're really missing out. Click the button, pack your bags, call your account manager, grab your boots, and I'll see you this June in Nashville.
What does a pharmacist do? Well, most people might answer that a pharmacist dispenses the medications that my doctor prescribes. Now, I work with a ton of great pharmacists, and one thing that I don't generally see is excitement about pills in a vial. And this is probably because pharmacists have been trained to do so much more. So what can you get excited about in your community? To find out, let's go beyond the scripts. Welcome back to Beyond the Scripts. I'm your host, Will Tuft, the Director of Education at PioneerRx. And on so many episodes of, well, really any pharmacy podcast, you hear so many interesting solutions for pharmacies that are really struggling with one or two of the base issues that are really root causes for many of the financial struggles at independent pharmacies today. And of course, if you look at DIR fees, if you look at low reimbursements, really most of the exciting things that pharmacies are doing are kind of blooming out of the necessity to stay above water in those really turbulent waters that's created. So how can pharmacies really dive in and address those root causes of low reimbursements, of DIR fees, of those things that are really so much bigger than your building? So really excited to dive into some of that today with Brandon Cooper of Sue's Pharmacy in Arkansas. Also, not just of Sue's Pharmacy, but of the Arkansas Pharmacy Association, of the CPESN group for Arkansas. So a very active member in the pharmacy space in Arkansas. So thanks so much for joining us here.
Thanks, Will. Happy to be here.
Yeah. So tell me a little bit about Sue's Pharmacy and kind of where you're at on the pharmacy side before we dive into some of those bigger roles.
Well, Sue's Pharmacy has been here for over 50 years. I know we celebrated our 50th anniversary. It seems like yesterday, but that was probably about 10 years ago. So we've been in the Jonesboro community for going on 60 years now. And I actually started working here when I was in high school. So I started my senior year in high school doing deliveries and started as a pharmacy technician. So went away to pharmacy school and gradually found my way back here as a pharmacist. So we kind of have been at the cutting edge, I feel like, in Jonesboro and getting immunizations started. I know we've always been politically active and kind of working in the advocacy side of things. So Sue's is a pretty strong, vibrant part of this community, and we hope that continues on into the future.
Yeah, I love that. I love that that long, local connection to the pharmacy, but also, the extremely forward-thinking and proactive, mindset within that pharmacy to make sure that the next generation is able to work there in high school and hopefully come back as a pharmacist years later. So really exciting. So you guys do an awful lot at Sue's Pharmacy. I was looking at the website. I found numerous articles from local news stations, from pharmacy publications, where you talked about various things at your pharmacy. One of those being vaccines. So tell me a little bit about the vaccines. I guess pre and post COVID. It almost seems like it's everything has to be kind of looked at through that lens.
Exactly. Yeah. We actually started a number of years ago, started giving flu shots when that became more prevalent in Arkansas. Pharmacists were given the ability to give vaccines. And since that time, it's just increased within the state. Everybody noticed that, once they put pharmacies in kind of in their own little realm there of giving immunizations and vaccines, they just really took off. So we got a lot more people vaccinated through the years. And then we actually started then going into travel vaccines because we're located here next to a major university. And there are a lot of churches here in town that go on mission trips. So we kind of saw that as a niche area and decided to start doing that. So we were one of the few pharmacies in the area that were giving the yellow fever vaccine and then kind of grew from there. We had a few outbreaks of hepatitis A around the area that kind of boosted that. So people started noticing us a little more. And so we've given those. And then, of course, like you said, when COVID hit, then we were, right there ready to start giving those when that started. So that's only increased. And now as people started traveling again, then we've seen that the travel vaccines kick up. And we do a lot of off-site clinics. We go to some of the local community centers and a lot of factories and industries in the area that we go off-site and do clinics, not only just for flu and pneumonia, but we've also done the Hep A clinics as well as, giving the COVID shots when those became available. So that's something we hope to continue into the future. And I think that's kind of spread nationwide now to where it's, most people years past didn't really think of pharmacy as the place to go for vaccines. But now I think that's kind of at the forefront of everybody's minds because we really took hold of that opportunity that we were given and just really ran with it.
Yeah, for sure. And that's one of the things that we saw, a lot of during COVID and the months, kind of after the pandemic started to wind down is that independent pharmacies were able to answer that local need with COVID vaccinations. So when the next need arises for those patients, the name on the mind hopefully is that local pharmacy that was able to come in that time in need. So have you seen kind of a shift in your business where that goodwill is transferring over to those other product categories?
Yeah, we have seen that. In fact, we picked up a lot of business. Some of the chain pharmacies around town, people kind of found their way here and then they decided, hey, maybe if that was the first time they'd ever been in this pharmacy or even knew that we were here, especially those that live, in other parts of town. And we kind of became their new go-to spot. And so they're like, well, you did such a good job, with helping get our family vaccinated for COVID and helping us through that situation. We kind of like to start using you guys to fill all of our prescriptions. So yeah, it was really a good marketing tool, that kind of came out of all that.
Yeah, for sure. For sure. I mean, so many people, I think, just don't even, even look for that independent option sometime. I mean, if you're somebody that's not on, dealing with chronic disease states, if you're not going to the pharmacy often, you have, something from your dentist, you maybe just go to that big box store because, it's the one you've seen on TV. So that exposure is so important. So if, you want to look for silver linings, that seems to be one coming out of COVID-19. So I see those boxes on the shelf behind you that are much more prevalent now than before the pandemic. But I think that's another niche that's really it makes so much sense for independent pharmacy to kind of take that that heavy lift off of the local healthcare system and just kind of perform some of those point of care tests there at the pharmacy level.
Yeah, that's another avenue that we're going towards is the new point of care testing. With COVID, a lot of pharmacies were kind of pushed in to start doing that to kind of fill that void and that need where people couldn't get their tests done in the right amount of time that was good for them. And so, they kind of geared towards the pharmacies around. And so that's something we've started doing. And then in Arkansas, we've made a big push to start doing more, not only, testing programs, but the test to treat program. So I know that's something our legislature has kind of started to push in the state. And so hopefully that'll all be finalized this year and we can start, moving towards having those, get your strep and flu tests and everything. And then you'd be able to have a one-stop shop and then receive your treatment right there as well.
Yeah, for sure. What's the current process in Arkansas? So if you are offering, a strep test or a flu test, what's the current protocol? Do you need to have a collaborative practice agreement, or do you have any prescriptive authority in that situation?
That's actually all still, right now it's been approved, and then the state board has, had hearings on it, but it has to be approved through the legislative committee. So I think there's just one more little hurdle to go through once it goes back to them, and then it will be, a statewide protocol in effect. So then you would, have prescriptive authority for those type of things. And then
Nice.
another one that was added was oral contraceptives. So that should also go into effect this year. That one also has to be signed off on by the medical association in Arkansas. So once they see that protocol and approve it, then pharmacies that go through all the steps to go through that training. In other words, there's a training program that you'll have to go through. So once you've done all of those steps and it gets approved by the legislature and the medical board, then that's another way that we'll be able to be a one-stop shop for that kind of thing. So not only to test for strep and flu and COVID and receive treatments there, but then we can also start with prescribing oral contraceptives as well.
Nice. Is that just the CLIA waiver, or do you have specific Arkansas regulation outside of that?
Yeah, we'll have Arkansas specific. So once you receive your CLIA waiver and go through the proper training, then there's a step that you have to go through, here in Arkansas to be able to do that. So that's all. We're getting really close. So just a few more hurdles to go through, and then we can start doing those type of programs.
Nice. What are you seeing now with the, with the positive COVID test right now? Or is there like the oral treatments available where you're at? Have you looked into that? Have you started that? Are those actually reimbursing? What's that look like?
Yeah, we have, and it's kind of fallen off in the last few weeks. But when the height of the Omicron variant was pretty prevalent around here, we had quite a few people come in for the treatments, the Paxlovid and the Molnupiravir. And that's kind of where we're at with that, is we see what a barrier there is there once you have to, go and get a doctor to prescribe it and then come back to the pharmacy. So that's kind of, we're using that as an example to say, well, time is of the essence in a lot of those medications. You want to start them as soon as possible after you test positive. So I think people are kind of seeing that and say, well, yeah, that we need to get this kind of moving along, so where they can go to the pharmacy, get tested, then receive their treatment right away, instead of having that extra burden of then going to another provider and then having to come back. So we hope that that's one thing that'll push us forward as well. As for the reimbursements that you mentioned, that was another area. Once we provided the COVID vaccines and got paid, a fair reimbursement to give those. And it was kind of insulting to see, then a lot of the plans and the payers say, well, we'll pay you $1 to dispense this medication after you perform all these extra steps to make sure, the patient can receive that and give them the counseling and go through all their drug interactions. So we've seen a lot of the state payers that we've gone to have said, okay, we'll increase that to, 10, 20, 30, a little bit more of a payment for what actually services you're providing. So that's another way that people are kind of seeing, starting to see the value that pharmacists can provide, instead of, through the years, this ratcheting down of payments and reimbursements. So you kind of see people see more of a value. So then you have them kind of fighting on your side as well to say, hey, they deserve to be paid a little bit more for these important services that they're providing.
Yeah, and I think that's like a part of the story that the general public is just kind of in the dark about. Like I haven't seen that reported anywhere outside of, pharmacy news networks, where, the pharmacy has really had to struggle to get that initial $40 reimbursement on the immunizations, where they've actually had to go in, complete data entry, but then go into a web portal and try to reconcile the difference in reimbursements. And then when it came to the actual oral treatments, those were, not being reimbursed at all because they were outside the scope of the emergency relief. And, it was kind of a mess that the general public probably sees that pharmacies have lots of business because of this pandemic. But, it's really been a kind of an administrative burden on most pharmacies.
Yeah, exactly. And that's where advocacy, for your profession comes into play. So here in Arkansas, we've been pretty strong with that. And we've got a lot of the news media and the local legislators to pay attention to that thing, as well as your local community leaders. And, we've really done a good job in Arkansas in educating the public and the major players in these areas to see, this is an important issue and we're not being properly reimbursed. So it's good to have someone extra on your side. So I think we've done pretty well in Arkansas about that. And it's good to see that kind of spreading throughout the nation as well now.
Yeah, there's a couple states that I think are really influential or definitely I don't know if it's just that those states are the squeaky wheel or if those states are really forward thinking and have, more resources allocated for advocacy. But, you think of North Carolina, you think of Arkansas, why are these universal problems only gaining traction, it seems, in some of those states?
Well, I think it all goes back to, the way the leaders in those states have started from the very beginning. And also you'll find a lot of the states that are really getting a lot of traction are those that still have a lot of the independent pharmacies around. So, you see them really pushing in their communities because, that's part of the tax base. That's part of, the people supporting your local teams and, events around your communities. And so once those independent pharmacies and pharmacy owners, make themselves a part of the community, not only in their local communities, but in their counties and the state, you see that kind of grab hold a little easier because it's a little easier for when the decision makers are your own customers and patients. It's a little easier, for you to kind of network and get your ideas out there and help them advocate on your behalf. So I think that's part of where your advocacy comes from in those states is just from having a lot of the independent pharmacies and then a strong pharmacy association that advocates on your behalf. And I know North Carolina, Arkansas, a lot of these states that are like that is where you see a lot of these groundswell of legislative activities happen.
Yeah. I mean, how much of that is just luck of the draw if you just happen to have a legislator who understands the healthcare landscape and wants to improve that versus, somebody who's maybe not as receptive or hasn't really it's really a lot to take in. If you're not familiar with it, it can really kind of be and is by design, I guess, very convoluted.
It is. And I mean, I won't lie to you. It takes years of doing that. I know when I graduated from pharmacy school in 2002, shortly after that, I started getting involved in our state pharmacy association and then served on the board of directors for a number of years. So I saw firsthand it took from then when we first started, trying to advocate on some issues important to pharmacy, whether it be provider status and paying for services, as well as PBM reforms and legislation to deal with, the abusive practices of PBMs and insurance middlemen. You've seen that take a number of years for us to just keep belaboring that point home, and then finally it takes hold. And I think you've seen that in the last few years because it started to affect people, especially, I think of the example of the workforce shortages. You see that happen a lot. So patients are kind of burdened by that if they're forced into these plans to use certain preferred networks or certain pharmacies like chains, but then they go there and suddenly those pharmacies are understaffed and it's going to take, hours to days to get their prescriptions filled. And we even had some in our local community that just closed out of the blue. And so that kind of brings it home then to those patients, and they're like, hey, maybe we need to start doing something. And then the legislators start saying, well, yeah, there is an issue. What you've been telling us all these years about low reimbursements and, not being able to sustain, local pharmacies, that affects people, especially you see after COVID when a lot of the pharmacies just couldn't properly service, a lot of the chain pharmacies couldn't properly service their communities. And then thankfully, there were still a lot of independent pharmacies here, that those patients could go to. And they're like, we really need these guys around. They're providing the innovative services that we need, and they're a part of our community. So we need to start helping to make sure that they're, that they survive.
Yeah. And when you have the, a three-letter team that is kind of making the rules that are advantageous for them and really hurt, the competition, they're kind of making up the rules of the game and then leaving the game. There's something like 900 stores closed recently for one large chain. It really does kind of, lead the question of, if they're making the rules and can't make it, how can the independents compete and thrive? It really seems like an uphill battle. But Arkansas has definitely had, some big wins in the news in the past couple of years.
Yeah, and I've kind of had a front row seat for a lot of that when we passed a lot of this legislation through my role on the board of directors. We would advocate, here in our state, and then suddenly when we passed these laws, then the PBMs kind of descended upon the state and decided to push back against that. So thankfully, the years and years of education and advocacy that we had here in Arkansas, we got the legislators to fight on our side. And then through Attorney General Leslie Rutledge, she took that case for our PBM reform and the legislation that we had there to pay the pharmacies fairly, took that all the way to the Supreme Court and won. So, yeah, that was kind of a tipping point, I think, for the rest of the nation. And we had a number of our legislators who were strong behind that original legislation were also members of national organizations of state legislators. So they kind of took our model here in Arkansas and said, let's use this as a template and apply to these other states. So then you just started seeing states across the nation just kind of fall into line and say, okay, this worked in Arkansas, it was upheld, so we're going to do the same thing here. And then you've seen other states, just like the other day I was reading about Georgia, they keep pushing the envelope a little bit now and saying, okay, these things have worked in our state and other states. We're just going to keep trying to push for a little more and make sure that, we can keep these local pharmacies viable.
Yeah, and so Rutledge was obviously a, high profile, big win. But I don't feel like that solves everything by any means, because basically that kind of just prevents pharmacies from being reimbursed below cost for some plans, right? So it's definitely not, hey, all the problems have been solved. It's amazing that a win that just says, hey, let's not get reimbursed below cost. That should be a no-brainer. It seems like that's something that you shouldn't even need legislation to claim that little bit of ground.
No, it's not. But part of what we did in Arkansas is we put the PBMs under the licensure of our insurance department. So the Arkansas Insurance Department has been tremendous in this effect. They've set aside a whole team of people working there and a legal team, and then other members who handle those MAC appeals. But they've also decided, there's a big issue here with these guys. Even they decided that they couldn't work with a lot of these big PBM players. So they've started issuing a lot of their own rules and regulations along the way. And I think I was just seeing the other day where now they're trying to simplify the process even further and hold them accountable. And so I think that's the next phase, is you'll see a lot of these states kind of take this on themselves and say, okay, now that we've won this and we've applied the MAC appeals and paying at least at or above cost, then let's start, rooting out the preferred networks, and let's get rid of these, behind the scenes backdoor ways to take back money. So I think that's going to help with each state doing that. And then we can work on greater things to get the DIR reform, through the U.S. Because that's actually in Arkansas now what the SCOTUS decision did was applied our rules for PBMs to go not only for state-funded plans, but it opened them up to the ERISA type plans. So now we can apply those same laws to the commercial plans, and then then you see pushback from PBMs and say, well, that doesn't apply to this because it was out of state, or this plan was developed before. And I think that's where the insurance department comes in to play, is they're pushing back against that and saying, no, that's not how we interpret that. So I think you'll see that in other states as well, as they'll start pushing back against this. And then once each state falls into line, then you'll see their national leaders kind of start kind of waving that flag as well. And you've seen that a little bit through some congressional committees where they're trying to work on the DIR reform and push back against this, as well as in the executive branch. You see CMS developed those rules to try to get DIR reform, and I hope everybody submitted comments to that so we can kind of get that done on a national level, because that's what it's really going to take to throw us over the finish line with this, is to get more work to be done nationally so we can apply this to all plans.
Yeah, I've seen the CMS calculation quite a bit lately. I mean, because it's pretty striking, But CMS acknowledges pharmacy DIR fees have gone up 107,000% since 2010. So that's obviously problematic. I think even if you're not familiar with any kind of pharmacy billing practices and how that all works, that definitely seems to be a problematic number. And I know on your, if you take a look at the Brandon Cooper Twitter feed, you're going to see a lot of those reposts coming from the hashtag DIR camp. So tell me a little bit about that. Like, how can people kind of help educate their peers and their community about those unfair practices, and what can they do to really fix that? Because it's bigger than one pharmacy. Nobody can really go fix that.
No, and I think that's goes back to the education and advocacy side. Some of our biggest advocates here at Sue's are our own patients, because they see how they're impacted. So I think it's just talking about these things with them, when they come in and they say, well, why is that so much? Or why am I told to go to this other pharmacy where it's cheaper? And I think if you'll just take a few minutes to explain that, then people realize that there's an issue. So then when you get them also on your side, along with your local legislators and your state pharmacy associations, if you get them to start calling those national leaders, your senators and your representatives, and educating them. So once they see more than just pharmacists out here saying, we're not getting paid, but once they see patients harmed, then I think that's where it starts hitting home, and they start saying, okay, there is an issue here when, people can't afford their medicine, and it's all because of these games that are being played behind the scenes, or these people can't get their medicines because they're waiting to get it from a specialty pharmacy or from mail order, and, it's taking weeks to months, to get issues like that resolved, and people are doing out their medicine. Then I think those national leaders start taking note of that and saying, okay, there's more here than just pharmacists not being paid for their
right.
for filling prescriptions or for services. People are being harmed.
Yeah, no, because pharmacy, a doctor, any profession, I feel like people have certain assumptions of, and if you hear a medical professional saying we're not being paid, the general person hearing that is like, oh, doctors make so much, they're fine. And it's really not. The margins have gotten pretty slim. And I feel like most people just don't understand the landscape that pharmacists especially are playing in. When you do see patients complain about drug cost, a lot of the time they're complaining about, they went in and got AWP as a cash price. Nobody pays that. Of course you can't afford that, because insurance companies don't pay that either. And then when you start getting into more of the, intricate aspects of the GER gaps and the maximum allowable cost, all of a sudden, it's just really too convoluted for most people to just understand what's going on and why it needs to be fixed. So can you give me kind of let's just take like a sample drug reimbursement and just kind of like run through a couple of those numbers that affect the billing. If you're talking to somebody who's not familiar, like, Brandon, I heard you on this podcast. What are you talking about? So maybe, if there's somebody outside of the pharmacy profession that wants to understand what all these numbers mean.
Yeah, and a lot of what I've seen are people using examples from, like, say you go to a department store, or you go somewhere else to buy another product and say, well, think about it as if you went there to pay for that, but instead of, just paying cash, you put it on a credit card. So you see one price listed on the tag, so you use that to pay for it. Well, then months later, the credit card company will come back and tell, wherever you bought, whatever department store you bought that from, and say, well, yeah, we understand this was the price that, that we put on there, but we're going to take back half of that and just keep for ourselves. So then you find that the the person buying the thing has paid too much because that really wasn't what was paid in the end. And then you have the department store, the person selling it, not really knowing what they're going to be paid. They think they're going to be paid one thing, and then weeks to months later, then someone, a middleman out here comes back and takes back part of that money. And so I think that's what we described in Arkansas, as we said, the marketplace is broken. And I think that's just the simplest terms to put it in is, the healthcare system in general is broken, but the payment system for pharmaceuticals is just a broken system. And you have all these, like you mentioned, the AWP, which nobody, pays that anymore. Then you have the NADAC price, which is kind of a better term, but that just deals with, how much the pharmacies are paying for that product. So then you have to add a dispensing fee to that. And then at the same time, then you have this MAC price that the payers will use to determine how much they're going to pay for something. And most of the time that can be below what your acquisition cost was for something. So there's just all these terms and all these payment models that just something's got to be done to make that, a little bit better. Because then on the whole flip side is you have the pharmaceutical companies, especially the brand name manufacturers, then what they charge is not what they're receiving either, because they're having to pay back rebates to the middleman as well. So you just see everything points back to the person in the middle that's controlling the money, and they're squeezing this side of the equation, which, are the providers, being the pharmacists, by paying so little. But then on the other side, they're creating these formularies to play the drug companies against each other and then taking back a percentage of that. So I think some good examples that I point to are, in a lot of the congressional hearings, as they looked, back when they were talking about how expensive insulin is. You look at the price of insulin, and if you break it down, from the production cost and how much, the wholesaler marks it up to then how much the pharmacy pays for it, and then you see the amount that the PBM takes out of it. And I mean, it's just, if you look at it in that situation in a pie chart, it's like there's so much money in that system that's just, what are we going towards? Are we getting better outcomes because of this? Or is it just how the middleman can make more money off of the equation? I think that's where we're at now in this country, is that people are seeing, we're not getting the value for what we're paying out in our healthcare dollars.
Yeah, I was reading an article the other day that Tim Mitchell posted on social media. I don't remember where the article was, but he mentioned that, or the article referenced that, and I think it was an insulin example, but the reimbursement for the pharmacy had dropped by 60%, and the copay had increased, so the patient responsibility had increased by 60%. And so it's just really only one kind of one party is benefiting from all of these changes. And at some point, it's just not sustainable, I would think.
No, it's not. And I mean, another example is you look back to the EpiPen situation, when people realized how much, this simple product that can save someone's life through, epinephrine injection, just how expensive that was. And then you look, I think they looked at it in a congressional committee as well and saw where, it's just a small percentage of that is actually how much it cost to produce that. And then it was just staggering how much was taken away through the equation, and then made the price of that, several hundreds of dollars that, markup on something that, is so simple. You think about that's been produced for years, and then suddenly, you see that with a lot of generic medications now. You see these prices just skyrocket for no reason, and it's kind of mind blowing. If you take the time to explain that to people, it is complicated. But then at the end, if you just say, okay, here's what these middlemen pay for something, and here's how much they charge, and it's there's a lot of leeway there, and you can see how easily it is for them to just increase their profit margin.
Yeah. And so, for the general consumer, when you look at it, why are my drug costs going up? Why can't I afford this copay? Is it, these pharmacists and their sports cars? Is it these greedy drug manufacturers? Is it the middleman of just a broken system? Where's the real problem? Because I think most people are kind of, given a narrative that it's just greedy drug companies, because it's not like that in other, they charge less in other countries.
Yeah, and I think you've seen that. It's kind of almost a pay to play model from their side. I mean, you can kind of understand where the drug companies are coming from in a lot of this because they're being squeezed as well, to try to negotiate to get their products on formularies, and they're having to pay out so much to these people. So yeah, that's kind of adds a lot in this country to the bottom line how much it costs people, and when you realize there's all these games being played behind the scenes. And that's where I think, through DIR reform, I think people are taking notice of that. When you mentioned that staggering number of how much it's gone up, I mean, those are just, it's kind of take it or leave it contracts that they give the pharmacies. And they're like, here's another way we can take back all this money from the equation.
Yeah. So, after Rutledge there in Oklahoma or in Arkansas, sorry, how has that changed the reports that you run in the system currently? Like, are you seeing a real difference where that's already kind of filtered down to, realistic improvements?
Yeah, we are. And then part of through Rutledge is, when we put it in our legislation, is to get rid of the same kind of thing as the DIR fee that they're using in commercial plans, where the GER and all of these other terms that they would take back money. So it got rid of that. So if there's any determination in a state funded or a commercial plan covered through ERISA, a group plan, if they're using those terminologies and not paying, actually what the cost is, if they're coming back on the back end, or if they're utilizing spread pricing, all of that, has been outlawed, and that's considered an unfair trade practice. So that's punishable through the Arkansas Insurance Department. So that's been one area where we've seen is they've started levying fines on these PBMs, where they find these activities going on. So that, number one, increased the reimbursement. But then there's also the MAC appeal side of things. So now we find when we appeal a lot of these prices, which, like you mentioned, you're getting back to the cost of the medicine, but it's still better than what you were getting. And so we've seen now that they know that, if they deny that appeal, we're just going to turn it over to the insurance department. Then a lot of them have started upholding those appeals on the front end. So, if you take the time to go through the process, which a lot of pharmacies in Arkansas have tried to streamline that process and work it into their workflow. And I know Pioneer has been a great help because we can, create reports so that we can just click buttons, and send it straight to the insurance department and say, okay, these guys aren't paying what they're supposed to. And then you'll find that they'll increase it. But overall, I think a lot of the PBMs have gotten wise, and they're like, okay, we're not going to get anywhere in this state by, just simply denying these below cost payments. So a lot of them, once we appeal, they'll, increase that payment. And then the insurance department also, like I mentioned earlier, has kind of taken upon themselves to create a new set of rules for them to follow. So if they see that they aren't, if they're upholding a MAC price 1 month, but then they turn around and lower it again the next month, then they're fining them because they didn't follow the law. Instead of increasing that payment and making it effective from this point forward, they're starting to fine them for that kind of practice as well.
So tell me about that process practically, because I've personally been in so many pharmacies where they see a negative reimbursement and they don't want to lose that patient, right? That's Jim. We got to fill it, right? Like, so what can they do? Like kind of run through your process for a MAC appeal and what's your success rate?
Well, what I've started doing in the early phases of it is, when we would run through and see that below cost payment, and we realized that it was a plan that was covered, which is now more plans. The only ones we really can't touch are the federally funded payers. So it would be Medicare and TRICARE, things like that, federal employees. But if it's not one of those plans, then, I'll print the screen out, put it to the side for a little later. And then most of the PBMs have their own process. A few of them just have an online portal where you just enter a few of the numbers and then submit it electronically to them. So you would submit that under cost payment to whichever payer it is. And then, within a few days to a week, then, and that's another thing that we worked on in the state was setting those time limits, so they can't just drag their feet, but they're, they have to do all this within 30 days. And so if they deny the appeal, then what I'll do is there's a report in Pioneer that we've developed. Some of the other members here in the state, Pioneer users, have developed a report that we can just simply print out. It fills in all the information. And then if they deny that appeal, we just send it to the insurance department and they handle it from there. So they'll get in contact and tell them to pay. And then so a few days to a week later, all within a month, then usually the PBMs will respond by email or send us a message and say, okay, go ahead and reverse and resubmit this claim. And then we'll be, made whole on that claim. So that's kind of simplifies the process. So that's where we'd like to see this taken, more to be able to do this for the federal plans would be nice. But, through that, you're going to have to get rid of, the DR fees and some of those below cost payments there. But our insurance department has been really good at kind of holding them accountable to following this law. And I know part of what they're working on now is they've issued a notice or a bulletin to the PBM saying, you've got to provide a better way for them to submit these appeals. Instead of just submitting one at a time, you need to develop a process so they can submit bulk appeals. And then on the flip side of that, also our law applies to NADAC claims. So if they're paying below NADAC on a lot of these issues, you can decide whether you want to submit it as a MAC appeal or as a NADAC appeal. So some of the pharmacies around the state have simply, developed a spreadsheet that they just send to the insurance department. So they'll just run a report from Pioneer, that compares everything to NADAC. And if it's paid below, they submit it. And then in a few weeks, the insurance department will work on it and, they'll receive the added payment back from the PBM. So there's more than one way to do this, but it's nice. You'd like to be receiving more than just simply your cost, but at least you're in a better place than you were, 5-10 years ago.
Yeah. And so, what's interesting is that you're fighting for low ground. You're fighting to recover cost when at that point you've already, spent your staff time, the materials to dispense, your labels, your vials, any transmission fees that are included with that. And then now that extra administrative burden to go back and then resubmit and reprocess all of those. Are you able to recover, a dispensing fee or, any of that in the process?
Yeah, that's kind of what we worked on a lot of our Medicaid plans. They've gone to this NADAC plus a dispensing fee model. So I think that's going to be the next area that we look at is can we apply that to more plans? Can we legislatively now through our wins, on a national level through the Supreme Court, can we push some of the state legislatures to set a floor and say, okay, here's a minimum dispensing fee. So then you not only have your MAC appeals, but we're going to say, okay, you've got to pay the cost plus a fair dispensing fee. So I think that's where you'll see a lot of the states start moving from this point forward, and is kind of push for that to recover not only your costs, but the time and effort it takes. So I think that's where you'll see the cost plus dispensing fee model kind of take more effect.
Yeah, and I can only imagine where, you have so many states right now where you have really amazing pharmacies that are really helping their community in so many different ways with so many different enhanced services to try to cover those losses on the actual products that they dispense. What a great change, what a great landscape that could be. If you're at least not fighting those really, pointless, should be a given battle just to recover cost on those drugs. So if you are a pharmacy who is not currently, helping to kind of hashtag end DIR or just to help advocate for their local, for their state, what advice do you have? Do you think pharmacies should reach out to those state associations? Should they be in CPESN? Should they call NCPA? What's your call to action for somebody who's currently inactive?
I think all of the above, everything you just mentioned. I mean, you've got to not only advocate yourself through your profession, but you've got to involve other people in your community and let your patients start fighting on your behalf. And another way to fight back is to start providing these other services and just get the PBMs out of the way. And I think that's what we've done through CPSN. I was kind of in the group that initially started the the Community Pharmacy Enhanced Services Network here in Arkansas. And now you see, I think it's in practically all 50 states. And so that's where you can start, going straight to the payers and say, hey, here's something else that we can provide to save you money. Not only is this, treating patients better and providing a better level of care, but by paying us, adequately for these services, we can save you on other spending sides. So I think that's where CPSN, can come into play in your state. And if you're not a member of that, then reach out and find out through your state pharmacy association and through your state if there is a CPSN and you want to get more involved in that, because you see that's where a lot of the advocacy and everything came from through the COVID vaccines and also the COVID antivirals, as you saw CPSN step up to the plate and say, hey, we have this network of pharmacies all throughout the country and we can start providing these services today. And then we have a mechanism available to pay for it and communicate with them. And so I think that's just a vital network of community pharmacies who want to differentiate themselves from, your regular dispensing pharmacy and say, we provide these services. We're part of a collective group that can help, save money in the long run and provide better care for you and your family. And so I think that's kind of where everything is geared towards now. And like I said, you just got to become more active through your local, not only your local legislators, but also your local, your leaders, all the way to, become active in your school board, start advocating in the local level to try to show people what you can do in your community. And then that kind of works up to your state and your national leaders. So if you just take the time, I know pharmacists are busy, and especially now with the workload and everything and not being paid adequately, but you've got to take that time to become more active in your community and in your pharmacy association to try to help better this profession.
Yeah, for sure. Capitalize on all that goodwill from all that hard work during the pandemic and, sure, take a weekend, go take a vacation, but, keep on that, that press that has really brought independent pharmacy to the forefront over the past couple of years. So thanks so much for joining us. This was a fun talk. I hope somebody out there picked something up. If you want to learn more about #NDIR, you can search for that. You're going to find so much great information from so many different sources that have that hashtag I've been seeing. So always just a great way to find some great articles. But Brandon Cooper also has a pretty active Twitter. Do you want to throw out your Twitter handle if you're into pharmacy issues or Memphis basketball? Great person to follow.
Yeah. Razorback, Arkansas Razorbacks or Memphis Grizzlies. Yeah, I'll keep you updated on that as well. But I think I think it's @CoopRx is my Twitter handle.
Good deal. All right. Well, thanks so much for joining us. I'll see you here soon, hopefully. Maybe I'll run into you in person this summer out there on the trade show circuit. So look forward to seeing you.
Yeah, it's been a pleasure. Thank you.
All right. Thanks, Brandon. Thank you for listening to this episode of Beyond the Scripts, presented by the Catalyst Pharmacy Podcast. If you enjoyed this episode, please support our channel by liking, subscribing, and clicking the notification bell so that you'll be notified anytime we post new content. To stay up to date with all of the latest independent pharmacy news and content, follow PioneerRx on your preferred social media platform.